Next speaker is Dr. Shalin Shah, and he will be speaking on alterations in retrobulbar hemodynamics following orbital decompression surgery in thyroid eye disease. And I'd like to request Dr. L. Vijaya ma'am to be the discussant. Dr. Kuresh Maskati will be the discussant for this.
Yeah, so good evening. I'll be discussing about thyroid eye disease orbital perfusion changes. So as we all know the Rundle's curve, there is an active phase, which is the dynamic phase. The inflammation increases and consequently the orbital perfusion increases for initial 12 to 18 months, followed by an inactive phase when the inflammation decreases and the orbital perfusion has also been described in the literature to decrease beyond the normal orbits. So the orbital perfusion we measured using color Doppler imaging in central retinal artery, that's CRA, and ophthalmic artery, OA. Here the peak systolic velocity shown with the red arrow and the end diastolic velocity shown with the blue arrow were measured, and the Doppler waveform is shown, and the resistivity index was calculated as per the formula shown. Now the literature does not accurately describe the effect of orbital decompression on arterial perfusion parameters in thyroid eye disease patients. So we conducted this thesis, and we included moderate to severe inactive non-smoker adult patients. Any disease which could affect the orbital perfusion, systemic disease, were excluded. We had three groups. Group A, which underwent orbital decompression surgery after a euthyroid phase, where a lateral wall and fat decompression was done. Group B, we had moderate to severe patients who were observed for 3 months, and group C, there were 18 healthy controls with refractive errors who were analyzed. So our demography and baseline parameters match the epidemiology for thyroid eye disease described in the literature. Now these are our pre-op and post-op photos where we can see post-decompression the proptosis has decreased. And coming to the Doppler parameters, so our proptosis intraocular pressure significantly decreased. Now the peak systolic velocity and end diastolic velocity in both CRA and ophthalmic artery, they increased significantly, whereas the resistivity index decreased significantly in both the arteries studied. So these are our Doppler images, patient 1 and patient 2, and we can see the Doppler waveforms in each pre-op and post-op, how it has significantly improved post-decompression surgery at 3 months. The group B, which was observed for 3 months, TD orbits, they showed no significant changes in Doppler flow. And the group C, which were healthy controls, when they were compared with thyroid eye disease, the diseased orbits had reduced velocities and increased resistivity index. And all the Doppler parameters showed a strong correlation with duration of thyroid disorder, that is duration of Graves' disease. We also did an area under curve analysis, and we compared the healthy with thyroid orbits, and we found that ophthalmic artery peak systolic velocity had the maximum discriminatory power, and we established some cutoffs. We also used it to distinguish between mild and moderate to severe thyroid eye disease patients. The mild patients were the patients in group B. So, and we found that ophthalmic artery EDV was had the maximum discriminatory power. So the Doppler placement of the gates have been shown in this anatomical picture, and lesions which are proximal to the Doppler placement gate will affect the peak systolic velocity, whereas the distal lesions will affect the end diastolic velocity. So the site of vascular resistance could be the orbital apex, it could be the fibrosed muscles, it could be the fibrosed adipose tissue in the orbit, or it could be the intraocular microvasculature. So from our study, we propose that the resolution of orbital space volume conflict following decompression surgery would improve the arterial perfusion, and this could in turn reduce the occurrence of ischemic dysthyroid optic neuropathy. Intraocular microvascular changes have been described in literature, but we did not study in our protocol. So we could not correlate OCTA findings, we could not see the venous changes and the posterior ciliary artery changes, small sample size, short follow-up, and no randomization. So serial monitoring of color Doppler parameters could be helpful in predicting TED progression, and it could be a determinant for early orbital decompression surgeries which have underperfused orbits. Thank you.
You see, are you making out a case that every thyroid eye disease patient who's got proptosis needs a decompression? So as because every one of your patients who had a decompression improved their perfusion and reduced their Poisson index?
Yes, sir.
So are you making out a case for an aggressive decompression for every?
Sir, what I would like to point out is that we found a discriminatory cutoff during our study between the mild to moderate to severe and between healthy and thyroid eye disease orbits. So whenever our suggestion is whenever the velocity values are below the cutoff, there is an increased risk for orbital ischemia and ischemic optic neuropathy. And so decompression may help, but we would like to have a larger sample size and a longer follow-up, and we would like to correlate with the intraocular changes, whether actual ONH vascularity is altering after decompression or not, which we could not do as a part of our study.
See, because we have a large volume of thyroid eye disease patients.
Yes, sir.
And the numbers of thyroid eye disease patients who develop an optic nerve head perfusion issue is very low. So in spite of no decompressions being done in practical life, I agree with what you're saying that no one has done these type of studies, but what you're showing is fairly logical, but it doesn't lead to a conclusion that you should do a decompression, because even if you leave them alone, I'm not sure what your cutoff. It's an arbitrary cutoff that you have chosen.
No, sir. We got it from the area under curve analysis and Uden's ratio, that whatever had the maximum sensitivity and specificity without going for aggressive decompression in well-perfused orbits. And sir, the concept of this thesis came up from there are a lot of studies which are suggesting that even patients with Graves' disease and without features of TED have optic nerve head perfusion changes, and if we could identify these patients early, it could be a reversible process. But beyond 4-5 years, when the fibrosis of all the orbital fat and muscles has set in, then it becomes an irreversible process. So,
okay, thank you.
Thank you, sir.